Computer. Okay, all right. So today's talk is actually a very basic talk, but actually it's surprisingly very important. I'm surprised how many people get this wrong in the exam. I promise you, this one and insertion of an intercostal chest drain. These are the two places where a lot of people get it wrong, and it is something that you do every day in your career. So the problem is, if you get it wrong, then people will question you severely. Okay. So I think it's quite important to make sure that you know this topic inside out. Everything possible you must know about it. But before I start my lecture, today's lecture is actually dedicated to my student. Okay. And my most important thing is this young boy. Okay. Kamran Ali started training with me, I don't know, 5, 7, 8 years ago, 6, 7 years ago. He came to me as a young graduate, did not know even how to put in a chest drain. And today, just hot off the press, he sent me an image saying, "Sir, I have done my first independent lung retrieval in Austria." So I am so proud of him. As he was getting onto the flight, he phoned me and he sent me a message saying, "Sir, you're the first person I want you to know that this is what I did today." So I am really feeling very, very proud. As a proud father, I'm sitting here. So this lecture is dedicated to Kamran. Very proud of what he has achieved and really an ideal student. I mean, honestly, his success in life has been perfect. So the whole lecture is for him. Okay. All right. So let's talk about alveolar air leak. Alveolar air leak, it's important to understand what is alveolar air leak. It's important to understand what is persistent air leak. It's important to understand what is bronchopleural fistula. Okay. A lot of people make this mistake. I have a lot of people phoning me saying the patient's got bronchopleural fistula. What should I do? But actually, there is a difference between a alveolar air leak, a difference between a persistent air leak, and a difference between a bronchopleural fistula. So any parenchymal leak distal to the segmental bronchus into the pleura is called as alveolar air leak. Okay. And that happens in about 50 to 65% of lung resection patients. And it is quite important that before you finish your surgery, before you get out of theater, before you start closing, you must actually on table do a water puncture test. And I'll show you this video a bit later, I think. So everybody on table must, before you finish doing thoracic surgery, before closing the chest, you must put in water into the chest and allow the lung to re-expand to make sure there is no air leak. And then depending upon what is the grade of air leak that you get, you decide whether you need to close it surgically or put in some sealant or something like that. And we'll discuss all that in a minute. Okay. All right. So I'm sorry, my animations have gone haywire because I didn't check the presentation before. So as I said, alveolar air leak versus bronchopleural fistula is very important to differentiate. Any parenchymal leak distal to the segmental bronchus, as I just told you, is alveolar air leak. It is not BPF. Okay. Anything that comes from a segmental bronchus upwards all the way up to a pneumonectomy stump is a bronchopleural fistula. So there is a huge difference in understanding the two concepts, because when you understand the two concepts is when you understand what are the treatments, because treatments of the two are completely different. So if you talk bronchopleural fistula, you are making a huge mistake. You will not treat it the way an alveolar air leak needs to be treated. Okay. So everything that I talk about is going to be around these two numbers. And there is a third concept called as prolonged or persistent air leak. For me, a prolonged air leak is flow more than 20 ml per minute over 24 hours, or an instantaneous more than 200 ml per minute after 5 days of surgery. Okay. Can you just switch off your microphones, please? Whoever is there, I tried to switch it off, but somebody switch it back on. Switch off your microphones, please. Okay, that's good. All right. Okay, so this is important to understand what is alveolar air leak, what is prolonged air leak, and what is bronchopleural fistula. Okay, all right. Literature, there is a wide variety of papers. Some people talk about 7 days, some people talk about 10 days, Some people talk about various things. But if you look at the STS database, the STS database defines prolonged air leak as something that lasts for more than 5 days after surgery. So my suggestion to everybody would be that all the other definitions are historic. We must now look at the latest definition. STS has the largest data coming into its database. So we must, all of us should use the same terminology around the world. So whenever you tell somebody on the phone that, sir, this patient has got prolonged air leak, I'm automatically assuming that he's more than 5 days post-surgery or more than 5 days post-insertion of an ICD. So it's important to understand this definition, quite important. The incidence of prolonged or persistent air leak is 9.7 to 15% of all air leaks, okay? So we said that about 50 to 60% of patients have air leaks after thoracic surgery. Out of this 50%, about 9% will actually go on to become prolonged air leaks. So before we talk about air leaks, we must understand what is grading of air leaks. There are 2 or 3 types of grading. Clinically, if you look at Maccarini's paper, I think 2012, he grades the air leak like this, and this is important for the exam, okay? Because this will come, we will ask you this in the exam. So 0 is no air leak. Number 1 is countable bubbles. Number 2 is a stream of bubbles, and number 3 is a coalesced bubbles. Okay, this is Maccarini's paper. This is how he's graded it. There are other papers who have also spoken about single stream, 2 to 5 discrete streams, more than 5, or coalesced streams. Okay, I get more and more confused with the grading if you do more and more this sort of single stream, discrete stream, because nowadays we are actually in the world of digital suction devices, and in digital suction device you can't see any of these things. So for me, the best grading is actually Serfolio's grading, and this again is quite a recent paper. It got published, I think, a couple of years ago, if I'm not mistaken, and Serfolio calls it as grade 1, grade 2, grade 3, and grade 4. And personally, this is more relevant to me than bubbles and how many bubbles are coming and things like that, because you really don't bend down and keep a tab on how many bubbles are coming. So a grade 1 is called as during forced expiration only. So this gives you a clinical picture of what is happening. So only when he's taking a deep cough and when you ask the patient to take a deep cough, you get a few bubbles, that's a grade 1. Grade 2 is when passively he's sitting, but on expiration he's getting an air leak. That's grade 2. Grade 3 is when he's getting inspiration. Okay, so even on inspiration, when he goes in, he's getting air leak. That's grade 3. And grade 4 is a continuous bubbling present both during inspiration and expiration. So this clinically is a better way to grade. If you're asked in the exam, I personally would talk about Maccarini's and then talk about the Serfolio's classification of air leaks. Okay, and it is important to know these classifications. Otherwise, it won't look good on your this thing. Okay, again, yeah, please switch off your microphones. Yeah, come on, what is the problem? Do you want me to not allow participants to switch on microphones? I can do that. I've just done that. So if anybody else wants to talk now, you have to ask my permission. But problem is I won't remember to ask that, to unmute that. So just please switch off your microphones, please. Okay, so where were we? I think Adnan asked me to talk about this. Adnan said he was asked this question in the exam. So I put it in the context of this discussion just for completion. There is some suggestion of what do you do when there is how do you calculate the percentage of pneumothorax? And the standard thing where you start acting is when there is more than 20% pneumothorax or more than 3 centimeter gap in a pleural space. 38% of these, this straight out of the paper, straight out of ESTS textbook, and it says 38% improve with suction, chest physiotherapy, bronchodilator therapy, and bronchoscopy. So this actually MCQ comes in the exam where they ask you what is the percentage of pneumothorax and what do you do in that situation. The important thing to remember is 10% of patients still have residual pneumothorax at 3 months. Doesn't mean that you have to put in an ICD into all patients. That's the important thing to understand. Unless the patient is clinically unwell or if there is bubbling, then that's different. But non-expansion of a lung does not actually indicate that the patient is unwell. It could be that on table you didn't allow the lung to fully expand and you closed the chest and then you had a space left over. Again, if you've done a lobectomy, it does take time for the lung to re-expand and fill up that space. So 10% of patients still have residual space at 3 months, particularly when you're talking about tuberculosis surgery or aspergillus surgery. You may have fibrotic lungs which may not re-expand. And sometimes if the patient is clinically well, you accept the picture and you say it's okay, all right? So this is the way you calculate. Again, this I put in, this is not part of the lecture per se, but this is for Adnan's request. How do you calculate the percentage of pneumothorax? So what you do is you take in the chest x-ray and you draw the lines A. Can you see that? So height and width. And then height into width will give you a number A. So you have to multiply 30 by 15, which gives you A. You have to mark out the lung, which is collapsed on the within the thoracic cavity. And then you do height and width. So height into width gives you B. And then A minus B divided by A is the ratio. And then you multiply it by 100, that gives you the percentage. It's called as Kircher's and Schwarzel's technique of measuring percentage of pneumothorax on a chest x-ray. Okay, it's very easy. Height and width, multiply the two together, you get A. Height and width of the collapsed lung, you multiply the two together, you get B. And then A minus B divided by A into 100 gives you the percentage of pneumothorax. Okay, so that's the way to calculate pneumothorax. All right, so let's get on to the topic of air leaks now. Is air leak a problem? Can we do something to reduce it? Do we have any options in our hands, or is it something that we have to accept? Are there any intraoperative strategies that will help us to manage air leaks? And what are the post-operative strategies that we can adopt to take care of air leaks? Air leaks are a big problem. I promise you, they are a big problem. They give rise to pain because of prolonged chest drain being inside. They are a source of infection because you cannot pull the chest drain out. Foreign body in the chest is equal to pneumonia, is equal to empyema. So bad news. Decreased mobility. Obviously, the patient with the chest drain hanging from his side cannot move very well. So they are higher risk of DVT and PE. So it is not a good idea. Very often you might actually put them through extra procedures and sometimes they go off and you might have to put them on mechanical ventilation and they might even need ICU. So it is a real problem. Longer drain dwell time means longer length of hospital stay, and in the current scenarios where it's so expensive to keep people in the hospital, there are huge cost implications of patients staying back in hospital purely because you cannot get rid of the chest drain. And of course, not to talk about the psychological problems for the patient, because really patients in hospital are not the best places. Really patient need their own food at home and they need their own toilets at home. So they have a huge psychological problems when they're stuck in hospital. And the problem is when you come on a ward round every day and you look there and say, let's wait one more day, it is very demoralizing for the patient because you cannot do anything, the patient cannot do anything, and it's a very frustrating situation. And most of us as surgeons have been in this situation where we do the waitful watch technique and we say, okay, tomorrow it will settle, and then tomorrow it doesn't settle, and then the next day it does. It really depresses the patient and it pulls them down. So air leak should be taken very seriously. At every stage of your operation, you must try and make sure that you get rid of air leak, okay? We did an analysis of our lobectomy data, which we published, Khalid and me. And, when we did the univariate analysis for predictors of length of hospital stay, the one factor which came very strongly was air leak, okay, straight away. So this was a very strong statistical analysis, and we clearly found out that in our VATS lobectomy groups, our results were getting skewed because there was air leak. So we adapted a very stringent strategy to reduce air leak on table. Again, a multivariate analysis came up with the same answer. So it's very important to make sure that you stop air leak on table, particularly when you're doing a VATS surgery. because the whole program of VATS really becomes successful when you can follow an ERAS guideline, which means you admit the patient on the morning of the surgery, you operate. Next morning on the ward round, if there is no air leak, you take the drain out and get the patient home so that your turnover increases, the patient's hospital stay goes down. So the whole VATS program works on a concept of quick turnaround in the hospital, because you're investing in a lot of expensive tools, particularly on the robotic front. We really need to work hard on this thing. So it is very important for us on table to make sure that air leak stops. Okay. Again, every day extra in the hospital, just staying in a hospital is 600 pounds a day. But if you're in an ICU, that's, thousands of pounds more. So the hospital is actually a very expensive hotel. If you're just sitting in the hospital all day long with just an air leak but no real treatment being taken place, it's really like sitting in a hotel, and it is the most expensive hotel to sit in the current scenario. So very important to take care of air leaks. So what are the intraoperative strategies? How do we as surgeons doing open surgery, VATS surgery, robotic surgery, how do we make sure that these air leaks don't happen in the very first place? And what do we do post-operatively? So everything I talk today is from literature. So first and foremost, as soon as I finish my operation, I will insist on doing a bubble test. So there I am pouring water into my saline into my chest. I'm asking the anesthetist to re-inflate, and I will never close the chest till I've done this. And I will get the camera up close on my bronchial stump, and I want to see and make sure that there is no air leak. See there, this bubble would have been missed if there was no water in the chest. So it's very important that every single case that you do, you must look for the air leak. And then when you see the air leak, you decide whether you want to treat it on table by suturing it or whether you want to be conservative with it. Who is this here? Please don't do this here. What is this rubbish here? I can't deal with this. Can you see something on your screen, or is it me who's seeing this on my screen?
Everybody can see it.
Somebody
Can see it,
Everybody can see.
Seems to be Shubham. Written as a Shubham.
Yeah, whatever it is, yeah. Don't
Bubble
do this,
test.
please.
Bubble taste.
Don't write on the screen, because I can't work otherwise. Okay, 1 minute, just wait. I have to. The problem of doing this as a meeting is that you unfortunately end up with having to share your desktop. So, can you see my slide now?
Yes.
Yes, sir.
Okay, thank you.
Yes, sir.
Yeah, 1 minute, wait now. The problem is one behind. So don't write on your screen, guys. It really distracts me and I forget what I was saying. So intraoperative techniques are sorry, where was I? I was talking about the bubble test. Yeah. So good surgical technique is absolutely mandatory. Okay. Good surgical technique, and then other availability to you are pleural tenting, diaphragmatic paralysis, and pleurodesis. And I'll talk about this in a minute. Just let's go through good surgical techniques first. So gentle handling. You must respect the lung. You must respect all the other tissues around you. So do not handle it roughly. Okay, don't handle it like you're handling the bowel. The lung tears very easily, and particularly in elderly patients. So everything that you do should be gentle. You should not tear the lung when you're pulling and pushing, particularly when you're retracting. Very often I've seen, you put a Ramplis on the lung and then just pull and you get a big tear on the lung. That's not good. The other thing is you have to dissect along tissue planes. That is absolutely mandatory. Okay. Try to follow the tissue planes. A, you will get less bleeding, and B, there will be less tear on the parenchyma. But of course, in India and rest of Southeast Asia, because of tuberculosis, it's very difficult to find normal tissue plane. So it is something that you just have to deal with when you go there. I personally like to use diathermy. I am a great fan of diathermy, and if I have little holes on the surface of the lung, I might even buzz it with diathermy. That's supposed to be local little holes can be dealt with diathermy. Most other dissections, you can use harmonic scalpel. It is definitely less traumatic on the lung, and it allows you to work within the tissue planes. If you see leaks on table, then it's always a good idea to repair the leak. Okay, absolutely important. It's a good idea that you put in a couple of stitches on the table and try to stop the leak. Always, whenever you're doing any complex surgeries for inflammatory disease, I have seen this happen, that some people go in, if they're draining an empyema, for example, they will just go into that loculated space, drain the loculated space, do a little bit of dissection of the adhesions, and then they find that there's a huge amount of air leak. Because what happens is, if you don't free the lung all around, then the lung cannot re-expand. And then that one area becomes a source of problem, because the rest of the adhesions pull it down, and it keeps that tear on the lung open. So always, whenever you're operating on thoracic surgery, as a philosophy, I do it every single time. I take down all adhesions. Absolutely. Whether I'm going to go to that area or not, my post-op recovery depends on how well my lung will re-expand. And as a result of that, I want to make sure that all adhesions are taken care. And when I do a decortication, I do a complete decortication. I'm not satisfied till I have got the hilum free anteriorly, posteriorly, superiorly, and inferiorly, which includes taking the entire lung off the surface of the diaphragm. In tuberculosis, that's a difficult area where the lung is stuck to the diaphragm. And we do all of it by VATS, mind you. So if we can do it by VATS and we can open everything up, there is no reason for open surgeons to not decorticate the lung completely. Because really our success in decortication, I put it to only one factor, and that is complete decortication. Because that every single alveoli should be recruited so that the lung re-expands. Though you may get a lot of air leak on the surface of the lung, immediately as it re-expands, it touches the surface of the lung. And within 24 to 48 hours, you get pleurodesis and air leak stops. So you shouldn't worry about air leak. In fact, doing a complete decortication is a therapy for post-operative air leak control. Okay. And then when you're doing lobectomies, if there are no fissures and things like that, I am quite happy to do a fissureless lobectomy, which means I don't open the fissure. I come at the hilum anteriorly and I work my way from front to back or back to front, depending on whatever is the comfort zone. And I will take the structures first. And once I've taken the structures, artery, vein, and bronchus, that is when I lift up the lung and put a stapler across what would be the fissure. So I sometimes, many times, because of the adhesions and things, you cannot see the fissure. So now it's become almost a routine where you try to do a fissureless or a fissure last lobectomy. Okay, both the words are acceptable. Fissureless means you just don't go into the lobectomy, into the fissure, and fissure last means you staple the fissure at the end of the operation. So complete mobilization of the lung is absolutely mandatory to re-expand the lung and to make sure that it touches the chest wall. Okay, very, very important. On table, you have options of putting in a blood patch onto an area. If you think your stitches are not going to stick well, you just take the patient's own blood, put it there, and put a Surgicel on it, and that forms a patch on the surface of the lung. If you're going to do any of these techniques, then I suggest you do it with the lung expanded. Because when you expand the lung, if you do it with the lung collapse, then when the lung expands, the patch just flows off. Because the pressure on it just throws it off. So if you're going to do anything, including sealants and stuff like that, you must re-expand the lung and put it at least on 80% expansion of the lung. Okay, you have availability of something of the pleural patch. You can locally dissect the pleura and put it on surface of the lung and get a cover on it. You can create a pneumoperitoneum. This is especially when you've done a lower lobectomy and you're worried that the lung will not expand, then you can put in a Verey's needle into the abdomen and put in 500 ml air, and that will temporarily just lift the diaphragm up and give you approximation of the diaphragm to the base of the lung, and then the air resolves by itself, and gradually everything will then settle down with time. At least the air leak stops because of pleurodesis. So that's another technique. Some people have access to lasers, and lasers are really good for use on the lung because they are pneumostatic, and it is a good idea to consider lasers when you are doing metacytectomy, particularly when you're trying to excoriate out multiple metastases. Some of them, you may not be able to staple everything, particularly when it's a deep situated metastasis. So then you use a laser to cut into the tissue and take out the metastases, and then the laser, you buzz the raw surface, and laser has a very good ability to be pneumostatic. It actually stops air leak on the surface of the lung. So I have used this many a times. I'm very happy with this technology. And if you want, someday I'll show you how lasers work. So this is how they talk about prediction of air leak. You've got to understand the philosophy of the air leak. This is from Gray's Anatomy. And whenever you're looking at it, you've got to look at high areas and low areas. And most of the places where you will get high air leak are areas which are more aerated. So always look out for those areas. If you've got problems there, solve them, okay? It's very, very important to solve them. Sai Endamuri has published a very nice paper, actually. This video is from Sai's paper. He talks about apical tenting. So if the lung cannot go to the chest wall, then get the chest wall to come down to the lung. And you don't want to do a thoracoplasty. So on table, what you do, even by VATS, is just make an incision on the pleura and dissect extrapleurally. And the moment you dissect extrapleurally, this pleura will come down. It's called as pleural tenting, and it will cover the staple line. The important thing is to cover the staple line and the obvious areas of air leak, because you do the air test and you see. And then if you want to use natural tissue within the chest, use the pleura. It's a beautiful tool. So you dissect extrapleurally, bring the whole pleura down, and that actually helps to stop the air leak, okay? This is the technique of doing an extrapleural or a fissure-less lobectomy. Sorry, not extrapleural, fissure-last or a fissure-less pneumonectomy, where you go at the back of the hilum or the front of the hilum. So if you're going in a right upper lobectomy at the back of the hilum, you start with the bronchus, and then you go structure by structure as you get in, and you make tunnels outside the lung. So you're not touching the lung at all. All the dissection happens in this area. So the artery, vein, bronchus, everything gets taken in this area. And then once the whole upper lobe is devascularized and cut away from the main structures, you then just put your stapler across like this and create the fissure with the staple line. So this is a very nice technique to learn, and I would recommend all people who are doing lobectomies, you must learn to do this sort of lobectomy. It's a good technique and gives you good control of the vessels. On table, you do have the option of using surgical sealants. There are a lot of sealants in the market, and I'll just enumerate the few that are commonly used, okay? So fibrin glue is available, and you can use that as a tool for spraying the area. There is something called as autologous fibrin sealant, which is a Vivostat. Each one of this is just made up of a different chemical composition. So I'm just going to talk about the composition that it is, but you must know the trade name. So Vivostat is a fibrin sealant. Tacoseal is a nice patch. It works like a pleural patch. So it is available like a flat, like a Surgicel. And then it's a flat sheet. And then you take it, and wherever you've got air leak, instead of putting sutures through the surface of the lung, you patch it. You just stick the Tacoseal onto it, and surprise, surprise, it actually works very well on the surface of the lung to stop air leaks. In fact, it's a very good tool even for stopping bleeding. So a lot of people use it. The Japanese particularly use a lot of Tacoseal for thoracic surgery. There is something called as a pro-activated synthetic sealant. This is an adverse seal. Again, I'm not going to go into details of each one of these. This is not the talk today, but it's important to know these things. And then Progel, and Progel is the only US FDA approved for air leak, okay? So let me tell you about the other ones. The bovine serum glutaraldehyde, which is a bioglue. Fibrinogen thrombin Tizil, which we use quite regularly. A polymeric hydrogel called as CoSeal. CoSeal has two functions. One, it is pneumostatic, and more importantly, CoSeal can actually also prevent adhesions forming wherever it is sprayed. So you might actually, it works very well in pediatric surgeries where you're going to do multiple surgeries in future. So you don't want the heart to stick to the back of the sternum. And similarly, in adult cardiac as well, you can use co-seal, particularly when you're doing aortic surgery or you're doing elephant trunk in 2 stages. So you don't want adhesion, so co-seal is used. But co-seal is also used as a lung sealant, and there is a recommendation, and there are some studies which have looked at it, and it's a decent enough product. But the one that is used across the US is Progel. Most of the people in the US actually use this because it's biodegradable, which means that with time, it will just degrade and go away and will not stay there for the rest of your life. So these are all the sealants that are available to you. I'll just quickly show you the previous ones. So Vivostat, Tacoseal, Advaseal, BioGlue, Tisseal, CoSeal, Progel, and that's the ones. The issue with sealants are there are costs involved with the sealants, but whenever you are going to look at cost, don't look at just the cost of the sealant. Look at the cost of having a patient stay in hospital for 5, 7, 10 extra days versus opening one sealant on table. So that is the balance you have to make when you make this decision. So always make sure that you're not, trying to being penny wise and pound foolish. So very often I've seen surgeons do that. They don't open the correct device on table and then have some problems afterwards and end up spending 3 times more in the post-operative period. So cost is always a relative topic. You must balance things out before you decide use or not use of a product on cost alone. Of course, you have to look at the sealing property of the product. You have to look at the specific use, which are the ones which are actually licensed for use as a pneumostat. And the important thing with sealants, whenever you're going to use sealants, just like I told you with the blood patch, I've seen this many times, young surgeons saying, oh, open the co-seal, and then they don't expand the lung. They just go in there and spray the co-seal on a collapsed lung, and then do the underwater test and find that there is no air leak, and they're very happy. And then they come out and leave a drain and come out, and next morning there is bubbling on the chest drain, and they wonder. They say co-seal is rubbish. It's a rubbish product, etc., etc. The reality is that the moment you expand the lung, whatever is stuck on the surface of the lung, because the lung expands, it just flies away. So you have just wasted 15,000 rupees for nothing if you have applied it on a collapsed lung. So the trick to apply any sealant on the surface of the lung is to always have the lung expanded, at least 80%. That's enough to give you a view. Even if you're doing it by VATS, it doesn't matter. 80% expansion of the lung is enough to give you a view. You don't want to really blow it into your face, but make sure it is spread on an expanded lung so there's less chance of the sealant flying away when the lung expands. Okay, it's like a balloon. So you got to have the balloon up. If you put it on a collapsed balloon and then blow the balloon up, it's going to fly away. So that's something that you got to remember. This is how fibrin sealants work. This is the pathway they follow. And then sealants work in this fibrinogen, fibrin monomer, and they form a clot which sits on the area and stops the air leak. Okay. When you're operating, there are many ways you can deliver these sealants. There are 2 main methods. One is a drip method and one is a spray method. The drip method works very well when you're doing a small localized area. But when you've got a broad area to cover, then spray method works very well because spray gives you a larger cubic meter coverage as opposed to a drip method. Sometimes some of the sealants need to be so they are stored at a certain temperature. So you might have to heat them up to activate them, particularly Tisseal needs to be heated up to be activated to become a good agent. Because I do everything by VATS, I use the Diplo Spray MIS device. This is a very nice device because it allows you to spray evenly with the pressure. So the pressure allows you to reach all areas of the lung with a single vial. Whereas if you do dripping, it will all get localized to one area and that might not be adequate. This is available either as this tip, which is just a direct application tip, or you have this minimally invasive long tip. And this is the one that I use. I prefer the minimally invasive long tip. It has always got 2 solutions within it. And then this pressure device gets attached with a lure lock to the tip. And as you inject, that pressure disperses the tip over a large area. Okay. Co-seal is a synthetic sealant. The good advantage of co-seal is you can immediately open and use it, as opposed to TIS-seal, because TIS-seal you have to reconstitute, which takes about 8 to 10 minutes. TIS-seal is a sealant, so it is actually used for covering surfaces of lung to prevent air leak. So it's a pneumostat. But one addition property of TIS-seal is it has got anti-adhesive properties, and that for me is a problem, because many a times I am actually banking on adhesions and pleurodhesis for my air leak to stop. So that is what stops me from using co-seal, because if I have sprayed co-seal over a large area, then if there is some leak left behind, that area may not stick to the chest wall, and so that is actually counterproductive for me in choosing a sealant. So it's sort of it's a catch-22 situation. You must always check the leak underwater, dry the area, should not apply any sealant on a wet area. You have to dry the area. You have to reinflate to 70 to 80% and spray from a distance. Don't go too close. This is not just for co-seal, this is for everything. The moment you spray from a distance, from 1 ml, you can get 25 square centimeter coverage, which is quite a large area to get coverage for, okay? So there's a lot of data out there, prospective randomized studies, various, quite a lot of level 1B, 1C, 2A data, which is talking about use of sealants in thoracic surgery. And you can take it or leave it depending on what is your local strategies. I personally inject the phrenic with Marcaine. I am very keen on that. Whenever I do a lobectomy, particularly for a tuberculous patient, I just take Marcaine, and it gives you enough paralysis for 8 to 24 hours for the lung, for the diaphragm to come up and allow the lung to stick to the chest wall. So I am quite happy with Marcaine. Phrenic crush can be done, but should be avoided, because really it takes a long time for the for the phrenic to regenerate. But it can work in some tuberculous situations, aspergilloma situations. I do use phrenic crush sometimes. I don't cut it, I just lightly crush it, just enough to allow neuropraxia and to allow the diaphragm to come up. Every time that you operate on an inflammatory disease or on a patient with chemoradiotherapy, previous chemoradiotherapy, I will always cover my stump. That is my mandatory rule, whether I'm doing tuberculous lobectomies, or if I'm doing downstage lung cancer. I don't like to leave the stump behind. For extra 20-25 minutes, you will save the patient a prolonged air leak with the stump giving way. So I'm very, very cautious about it. I use intercostal muscle because I do it by VATS or robotics, and I can just swing the intercostal muscle down. The important thing when you harvest the intercostal muscle is that you got to remember to keep the vascularity intact. A dead muscle is no good, okay? So you need to, when you harvest, be very careful not to damage the intercostal artery. Make sure that you cut and tie, because the artery comes from the back to the front. So always cut and tie the front end so that maximum pressure flow comes into the intercostal artery. If you're going to do it by open thoracotomy, then you do have an option of serratus to be used as a muscle flap. A lot of people who do sleeve resections, I know Sai for one, whenever he does his sleeve resection by open technique, he will actually harvest the serratus first. As soon as he starts the operation, before going into the chest, he will actually, along the way of the incision, he will harvest the serratus and cover it with some vasodilator solution, and then go in and do his operation, and then get the serratus down through an intercostal space higher. He doesn't use the same space, he goes one space higher and then puts it around the sleeve resection that he has done. So it's a good technique to prevent air leak and to get stability of the area. But I cannot stress important that the one most important factor of post-operative problems is an incorrectly placed chest tube. you'll be surprised the number of times where the tube gets pulled back, or the hole comes into the chest wall because you've forgotten to tie it properly, or because you didn't place it all the way to the apex, so you're not draining the apex completely. So really, the number of times patients get surgical emphysema because the tube is not correctly placed is a real disaster for the patient. In a standard scenario, I use a 28 French drain whenever I'm doing empyema surgery, or whenever I'm doing hemothorax surgery. I will use a 32 French drain as standard. The drain must reach the apex because air rises to the top. So you must make sure that the drain doesn't get stuck in the bottom, or doesn't get stuck between the fissures. Very often I've seen people put a drain and it's lying between the fissures on the way to the top. So it's not good. It must be extra pleural, and extra pleural meaning within the pleural space, but extra lung, extra visceral pleural, not within the fissures of the lung. You must remember that any drain that you put in, no matter how well you tie it, when the patient is turned from a lateral thoracotomy position to a supine position, there is a pull on the skin and the fat, and all drains shorten by 2 centimeters. As a rule, they shorten by 2 centimeters. So whenever I am doing VATS lobectomy or something, my juniors will tell you, I will always oversize the drain, which means the tip of my drain doesn't reach the apex. It reaches beyond the apex and curls down by about 2 centimeters. So that when the patient gets turned over and then you take an X-ray post-surgery, you will see that the drain will lie exactly on the apex. So it is important to make sure that your drain is correctly placed and to understand that all drains shorten by 2 centimeters. Very, very important. Now, I use only a single drain in my clinical practice. Hence, I make an extra hole at the base for the fluid to come out, okay? If you are not comfortable with that, you can use 2 drains. I don't have a problem. But make sure whatever you do, you must drain the pleural cavity completely. And if you make an extra hole at the base, make sure it's not too low. Otherwise, that will get shortened and it will lie in the subcutaneous tissue. And all the air leak from the chest will go into the subcutaneous tissue, and you will end up with a surgical emphysema. So very, 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 very important. You may use 2 drains. I don't have a problem. Whatever is your technique, make sure that the drain is fixed well to the chest wall, because losing a drain post-surgery because the patient pulled it is a disaster, because putting a drain back in the ward, is not good for the patient's confidence, and more importantly, you will introduce sepsis into a post-lobectomy space, and that is a disaster. So a small thing like tying the drain properly is absolutely mandatory when you're talking about air leak control. Very, very, very important. It's a very small point, but it's exceedingly important. Okay, so post-operative strategies. Now, I don't like PEEP on my lungs whenever I have operated. I try not to give them, any positive pressure ventilation. And so I will always extubate on table. I actually stand in the theater many, many a times with my anesthetist, and I will say, even if you feel that he's going to be reintubated, don't worry, but please extubate on table. Try and extubate on table. And 99% of the times you get away with it. And so I'm very, very keen. I always connect my drains to suction. There are 2 philosophies, one off suction and one no suction. So I'll talk about that in 1 minute. But personally, I've always worked with suction, and I'm quite happy with that. I also do a chest X-ray and recovery. Again, I've seen papers, particularly in the UK and in the NHS, where they've said, oh, there is no need for doing a chest X-ray and recovery. But I feel that at least when I've done a chest X-ray, I know what is happening in the chest. I can see where my drain is positioned. I can see if there is any collection or anything stupid that's happening in there, or the drain is kinked and the patient is getting a pneumothorax. Stuff like that can be picked up. So I like to get a chest X-ray in recovery, and that's my rule. I don't hesitate on that. Portable suction drain, I use digital suction drainage. Topaz is an excellent tool. In my, I have worked in India over 10 years with the tuberculosis patients. And the only thing that I feel added value to my surgery of VADS decortication with fibrotic TB lungs is the use of digital suction device, because digital suction device gives you sustained suction, assured suction, because wall suction cannot be assured. It can go up and down depending upon what is the pressure in that area. But more importantly, it allows the lung to come up to the chest wall. And I strongly believe, and there is enough evidence now to show, that most air leaks stop because of pleurodesis, not because of what you're doing, sealants and all that. When the lung comes and touches the chest wall and it sticks to the chest wall, that is when air leaks stop. So this philosophy is very important. And that is why I personally use the suction quite a lot, and I'm quite happy with that. The other important thing is early mobilization. Mandatory, you must get the patient out of bed within 4 to 6 hours of the operation. He must sit upright. He must start doing his physiotherapy, his incentive spirometry, whatever you want, you must push the patient. I'll talk about incentive spirometry in a minute. There is a paper which says it is actually not good. There is no benefit with incentive spirometry, and I'll tell you about that. Suction or not to suction. Suction is a double-edged sword. Okay, it's something you've got to remember. I think in the first 48 hours, it's very good. It allows the lung to re-expand, pulls up the lung to the chest wall. But you also got to remember that after 2 to 3 days of surgery, it also sucks on that area which is causing the air leak, and it helps to keep the air leak patent. So it's very important to judiciously use the suction for 48 hours to 72 hours, but you must know when to turn off the suction and then get the patient to re-expand on its own. Because sometimes if the air leak is kept patent and the patient is continuously bubbling, taking him off suction will allow the lung to collapse a little bit. And when it collapses a little bit, A will touch B, which means the two edges of that air leak will touch each other, and then they will heal with fibrosis, and then the lung will re-expand. So this is a philosophy that you have to understand. It's a physiology of the lung. So just by using suction, keeping the two edges of the tear apart will not help it to heal. So sometimes you have to let go of the suction, let the lung collapse a little bit. Don't worry about the chest x-ray if there's a 20% collapse, because the collapse will pucker the lung and will pucker the two edges of that leak together, and it will heal, and then the lung will re-expand. So different surgeons have different protocols. I personally use 2 kPas, and I'm extremely happy with that. And within 3 days, if I have a problem, I think the air leak is not healing. There are 2 things you have to understand. One is it a major air leak, which means it's coming from a bronchus? Then I will go back into theater, because it is torrential air leak. I know it will never heal no matter what I do. But if it is just a subtle air leak, 200, 300, 400 on the Topaz device, I'm not worried. I'm rest assured that that will heal with time. But you have to be sensible enough and experienced enough to realize that the air leak is coming from the alveolar air leak and not from a bronchus. So if it's a bronchial air leak, within 48 hours, you just go back to theater and close it again. So it's important to understand the difference between the two. So there is a lot of data out there. There's a meta-analysis where they've said that suction does not add value to this surgery. So routine use of suction is actually not recommended according to this meta-analysis. But then they also say that early use of suction might be crucial to specific patients where a residual space is important. So there are many ways you can interpret. There are many other meta-analyses as well. Some for suction, some against suction. I think we have not answered this question as yet. So the important thing is the suction has to be right. If you are getting a wrong suction, which means that your suction is not on, then you are creating a completely blocked tube. If you know what I mean. I mean, if it is without suction, at least it's open to air, and any collection in the chest will drain out through an open channel at the other end. But if you've connected a suction tubing to that end, and the suction is not working, then you have created a closed tubing, and the whole system becomes closed, and then you will end up with a surgical emphysema or tension pneumothorax. So if you're going to use suction, it has to be correct suction. You cannot have a blocked suction. In that situation, it's better not to use a suction. But because of that, because I use a digital suction device, I know my suction cannot go wrong. The device works. And if the device is malfunctioning, and then I'll take out the device and keep him without suction. That's okay with me. Incentive spirometry is used quite aggressively in India and other countries. I've seen this. It allows patients to do physiotherapy exercises and allows them to cough up all the phlegm and things like that. But there's a very nice paper which has actually looked, and this is a really nice, well-written, well-done study, well-written study, which actually has looked at the effectiveness of incentive spirometry. And to be honest, in England, they don't use incentive spirometry as a routine until and unless there are specific indications where you want to encourage the patient and things like that. But routine use of post-operative incentive spirometry is almost given up in the UK, but still continues in England and in India and in other parts of the world. So we still don't know what is the answer to that. I mean, this is Rajesh Pala and Maninder Kalkata are one of the authors. So it's a very well done study. And in the UK, they don't really use incentive spirometry. I published this paper with an integration of robotic VATS and Ayurveda and yoga. And this paper has been extremely well received around the world. I get invites all over the world to really go and lecture on the benefits of integrative medicine. And what I do is because I worked in India, we have access to a yoga therapist and we have access to an integrative medicine physician. So all three of us are part of the team, and my patients are taught pre-operatively all these exercises, these deep breathing exercises. Now, I'm not a yoga expert, but I can tell you that my patients love it. In India particularly, they love it. So you teach them pre-operatively, and within 4 hours following the surgery, this guy will come back into the ICU or in the high HDU or in the ward, and he will start mobilizing the patients. And because these guys have learned these techniques, they start to do them very quickly. And we looked at our data and we analyzed the data, and in the paper we published, we found that the amount of drainage with use of yoga actually goes down. Intercostal, the lung expansion increases significantly, and the drain dwell time, that is the amount of time that the drain stays post-operatively, has significantly gone down. I'm not saying yoga alone adds to that. It's a combination of everything, all the things that I told you before, plus physiotherapy, plus yoga. It's a lethal mix which allows the patient to get out of bed quickly, and the lung re-expands. And the moment the lung re-expands, it touches the chest wall, the air leak usually stops. And that's been our experience with these things. So we've spoken about air leaks. We've spoken about what are the intraoperative strategies. We've spoken about post-operative strategies. Now let's have a look at prolonged air leak and try to understand what do we do when we are dealing with somebody who's got air leak for more than 5 days. So this is what I told you. This is the definition of prolonged air leak. Anything more than 5 days or a large amount of fluid coming over after 5 days is an air leak and should be is worrisome. There are a lot of factors which are risk factors for prolonged air leak. Predominant among them are lung conditions, age, advanced age, presence of previous radiotherapy, malnutrition, and each of this is actually from the guidelines and from the databases. Okay. Dense adhesions, redo surgery, steroid dependent, hyperproteinemia, incomplete fissures, a history of smoking, poor FEV1, residual cancer at resection margins predisposes to breakdowns, and the use of post-operative PEEP or positive pressure ventilation. All of these have, each one of this is a separate paper, and they've all been proven to be risk factors for prolonged air leak. And when any of these risk factors are present, intraoperatively, I become 2 or 3 times more cautious when I'm operating on these patients. I make sure that on table, I take all strategies to at least reduce the surgical air leak that I can physically see. I will make sure that I do everything. So I really push hard for this group of patients to make sure that we don't end up with a prolonged air leak in the post-operative period. Now, there's a little bit of discussion of 2 drains versus 1 drain. Actually, all papers, at least the current papers, have shown that there is no benefit of 2 drains. Putting in 2, 1 apical, 1 basal was a standard practice, which I trained in, and also using a figure of less than 100 ml as a cutoff point for taking out the drain. All of that has finished now. It's gone. It's in history. All papers that have looked at the outcomes, and these are good quality papers, have all said that there is no benefit of putting 2 drains over a single drain. Single drain shortens length of hospital stay. It shortens pain. Of course, if there is inadequate drainage, or if in the post-operative period you find that your drain is not doing well, or the patient's developing a surgical emphysema, go ahead and put in a second drain. That's not the problem. But to put in 2 drains in all patients, no matter whether you're doing a pleurectomy, bulectomy surgery, or small metastasis, is actually frowned upon nowadays. Nobody does that. Almost everybody has given up the use of 2 drains. Most of us use a single drain and extra long drains, but the old timers don't like it. Of course, you've got surgical emphysema, you put in a second drain. So there are a lot of trials. Look at the number of trials. All of them have looked, the first 8 or 10 of them, sorry, this is the other paper. This is the paper of digital versus standard wall suction. That's the other new topic, the hot topic in the exam that gets discussed. And if you look at this collection of papers, almost all of them, the recent ones with decent number of patients, are actually favoring digital suction over standard wall suction. There are a lot of problems with the wall suction because it's not standard available. Sometimes the device malfunctions, the pressure in the system doesn't work, and more importantly, the patient gets stuck to the bed and he can't go to the toilet. With digital suction, you just disconnect the lead, the power lead, and it has got a battery, and he can walk around and he can move. So we strongly suggest use of digital suction device. There are 2 types available. One is the Atmos and the other one is Topaz. It doesn't matter which one you use, but in the current scenarios, digital suction device is an excellent tool. It gives you a graphic recording of what happened over 24 hours. You can also look at what happened over the last 7 days, 6 days, whatever time the patient is in theater. And also you can download all this to your computer. So it becomes a very good database for a paper that you want to write in future. So if you look at the first 5, 6, 7, 8, all of them have favored digital suction. The ones at the bottom here were the earlier papers, and they did not find much difference between the 2. So they didn't say that digital suction was bad or worse than standard. They said it's just as good. But now the current papers that are coming through, almost all of them are talking about digital suction. So take a snapshot of this screen, and you can actually use this in the exam to talk about why you should use it. So 2 are available. Atmos, not Atrium, Atmos. I'm sorry about that spelling mistake. It's Atmos and Topaz. Those are the 2 that are available. Okay. All right. So what are your management strategies? Is it going okay? Is everybody happy so far, or am I going too fast?
Yes, sir.
Yeah, it's okay, isn't it? Because this is more clinical. I don't have to explain a lot of things. So I'm very happy to just move along, okay, at the pace that we're doing. So for persistent air leak, there are various management strategies. One is the medical or the conservative management strategy, which would include watchful waiting, suction, physiotherapy. Again, some people don't like suction, so we don't have an answer to that. Sometimes in patients who are not suitable for any surgical reintervention, you might actually consider bedside fluorodesis and just get away with it. But most of the patients, because you've operated and it's a post-operative patient, you actually want to do something surgically if the air leak has become prolonged. And surgically, if you have to do, you have endobronchial therapy available to you, and you have the possibility of surgical exploration and going in and sorting out the air leak wherever it is happening. So these are all the gamut of things that are available. If you do have to do bedside fluorodesis, then talc is a good agent. I personally use talc a lot. It's available in India. I told in yesterday's lecture as well. a group called as Rohit Surgicals has the thing, I think, and they provide you with talc. Talc is available as a powder solution and also as a pressurized solution. So you can make a talc slurry with 50 ml of saline, 1 bottle or 2 bottles of talc, and 20 ml of lignocaine, and then push it into the drain. But you must not clamp the drain because the patient has got air leak. So you have to add extra long tubings to hang the tubing above the patient's bed, so that you use an IV drip and hang it from there so that the talc doesn't pour out. And that you leave it there for an hour or two, as long as the patient can tolerate it. And then you achieve medical pleurodesis in these patients. The other agents which I have used is tetracycline. It's tetracycline now is banned. It's almost not available in any market. Luckily, we've had some stock lying around which we've used in the past. But nowadays, it's almost difficult to get tetracycline. You have bleomycin as well, which can be used as a local pleurodesing agent to achieve pleurodesis. You must remember that when you're pushing something into a post-operative chest, there is always a risk of infection. So whenever we do these procedures, we do them almost with surgical precision and surgical disinfection. We make sure that everything that you use, you do it like a proper surgical procedure. Even if you're doing in a side room of a ward, just make sure that you do not introduce infection into the chest. That would be a disaster. Some people have used blood. It was quite popular earlier. Still, I know of some surgeons who use about 50 ml of patient's own blood, autologous blood. But again, the worry is risk of infection. But blood is an excellent tool for causing pleurodesis. In fact, that is one of the reasons why we do pleural abrasion following some surgeries, because you want to generate a bit of blood and ooze on the surface of the pleura, and don't wash it out completely. Let the lung come up to the chest wall, and the moment the blood is there, it causes the pleurodesis and sticks the lung to the chest wall. So excellent tool actually for causing pleurodesis. But if you look at literature across the board for post-operative or post-surgical medical pleurodesis, there is a wide variety of outcomes. And some papers have said that with bleomycin, they had 85% failure rate. So really, there's a wide variety from 27% to 87%. I have read extensively on this subject. And I promise you, every paper has got a different rate. There is no standard guideline which tells you what is the right thing to use. But now almost everybody uses talc, and it's not your normal talcum powder, it's surgical talc, because it has to be of a certain diameter. The molecule of the talc has to be of a certain diameter so that it does not enter into the circulation and does not into the capillary circulation and does not cause systemic allergic reactions and things like that. So if you're going to use talc, please use surgical talc. That's the one that you have to use, okay? All right. Heimlich valve is a much touted technique for post-operative prolonged air leak, and I'll tell you about it. In India, in the UK, I use Heimlich valve, easily available, not expensive. In India, I use a urine bag with a non-return valve. I'll show you that in a minute. And I just cut off the tip and connect it to the bag, and it's a beautiful tool, works very well, gets the patient mobile very fast, okay? Then you have certain devices which you can connect and the patient can take home. So there is something called as a pneumostat device from Atrium, and there is a portable topaz, a small size topaz which they are making. So you send the patient home with these things. The idea of putting these valves is that you quickly mobilize the patient and send them home. So I'll tell you what my practice is in a minute. So this is how an Heimlich valve is attached. It's got a one-way valve in it. So the air coming out from there can come out, but no air can go back. It's a one-way valve. So it doesn't allow air to go back or fluid to go back, but air and fluid from the chest can come out into a bag or a bottle or whatever you want to use. This is what I use. If you look carefully, I've taken a snapshot of the center of the bag. It's got a one-way valve. It's a non-return flutter valve. And so every time you connect it to the patient's chest tube, the air will come out and collect into this area, but it cannot go back because of this non-return valve. The one important thing you must remember is that you must cut off this blue thing. Okay, it's absolutely, man, the number of times I've seen people make this mistake. is that they don't cut off this blue thing and send the patient home, and the patient collects fluid into this, and when he goes to sleep, some of it falls off. So he thinks, oh, there is a leak, and he seals this. He closes this cap. The moment you close the cap, you have created a closed system. If you create a closed system, rest assured he's going to get tension pneumothorax, because there is no way the air can come out. So you must, when you connect this bag, you must cut off this cap so that the patient has no way to close this seal off. So that any fluid that collects, he just has to keep it straight so that it doesn't fall off. And every morning he just measures it, writes it into his diary, and then throws the fluid away. So the whole idea is to throw the fluid away, not to keep it in the bag. I've seen people very proudly carrying 800 ml in it. That's not the point. The point is you have to throw the fluid in the sink every day. But the real reason why you use this is to allow the air to come out, okay? So this is a very good tool as a flutter valve in patients. So this is my strategy. Now look at how I deal with this. Whenever on the ward round, I've got a guy, post-operative patient, I'll put him on suction. I use Topaz. Within 2 to 3 days, if the air leak is not stopping, I am worried that it will not stop. I think it's significant. Then I will convert him to a flutter valve or a urine bag with a valve. The other thing that I also do with this patient is I will put in a little bandage, a long roller bandage, and tie this bag across his shoulder so that it becomes like a purse. So he can carry it on his purse below his shirt, and then he can wear his shirt on top of it. So I will very quickly to connect him to flutter bag. I'll keep him in the hospital for 24 hours to make sure that he's tolerating the flutter bag. It's not too much fluid, or he's not getting tension or anything like that. And then I will discharge him. Very quickly I discharge him. So within 3, 4, 5 days, he's out of my ward. Okay. Then I call him back into the outpatient the next week. Okay. I give him 5, 6 days for the thing to settle. I look at him clinically, and I want to see that flutter valve. And I ask him to cough. If he coughs and I see a flutter in the valve, a large flutter in the valve, then I will say, okay, it's still leaking. And I will send him back and call him back. If I feel that the flutter is not there, or the flutter is there, but a small amount because of the mediastinal movement, then I am very happy to clamp the drain. So in the morning when he comes to my clinic, he will have a chest x-ray. Then I will see him. I want to make sure on the chest x-ray that the lung seems to be expanded. Clinically, I want to make sure that there is no flutter on that flutter valve. And then next morning, what I'll do, so the same day, once I have seen that, I'll clamp the drain. But the important thing is, if you have clamped the drain, you must not allow him to go somewhere else to have coffee, tea, lunch, or whatever. He must stay in your clinical area for 2 hours. Because if he goes somewhere else and he starts to develop a tension pneumothorax, that's a disaster, because you've really clamped the drain and you've made the body like there is no drain. So if he starts to have a tension pneumothorax, he will collapse and die somewhere in the coffee shop downstairs. So he is not allowed to go out of my clinical area. You know, the nurse is there and somebody is always keeping an eye out for him, or a relative is there. After 2 hours, he goes down to radiology and he has a repeat chest x-ray. Once I have seen the repeat chest x-ray, if it is same as it was before clamping, then I know that the patient will tolerate the drain coming out, and I take the drain out. I just pull it out, and I always leave a purse string there, which I tie off. Of course, if I find that the chest x-ray is showing slightly increased pneumothorax, then I'll release the clamp. And nothing lost by it. The patient feels comfortable, and you just send him home, and he comes back 2, 3 days later or next week. And usually, I mean, 99% of the times, I have found by the next week, everything is stopped and you just take the drain out. And this way you reduce his hospital stay, and he gets to go home. That is the most important thing. Of course, if he's from outstation, then my hospital has got a lot of hotels around there, which are a lot cheaper than staying in hospital. So we send them to the hotel. But of course, he's got instructions that if he has any shortness of breath or any problem, he must come back to the A&E immediately. If for 3 weeks, I find that there is no resolution, that's my threshold actually. 3 weeks, if I find that nothing is happening, it's not improving, the guy is still bubbling, things are not going well, it's not reducing in size, then I will think about going back in and trying to do something. And most of the time we go back in by VATS. We don't actually convert anything that is VATS into a thoracotomy. To be honest, over the years, I've never had to convert a VATS into a thoracotomy to solve air leak problems. I just go in, buy the same incisions, and we have a look, and whatever is the problem, we will either stitch it or we'll put a sealant on it or a patch on it, and we'll come out. Sometimes I have seen patients, 1 or 2 patients, it's not been often that I had to go back in. Over the years, I probably think maybe 1 every 2 years that I have to go back in for air leak. And sometimes I see them at 21 days, but I find that the air leak is nicely tapering down. It has gone down. The patient is tolerating well. Then I'm happy to wait even longer than that. It's only when the air leak is persistent and the lung is down and not coming up, that is when I go back into the chest and solve the problem. Of course, post-operatively, if on the ward round, I found that the guy's got a massive air leak, which is not in keeping with the operation that I've done. I mean, if I've done an LVRS, that's a different thing. If I've done a massive decortication, but if I've done a straightforward lobectomy and then I find there's a massive air leak, or there is a grade 3 air leak and there is no resolution of that air leak. In fact, the next day the air leak has gone up, then I am thinking that my staple line has given way. Okay, and this has happened maybe 2 or 3 times over my career. And I really trust my staples quite a lot. I trust that the quality of staples that I'm using are really good. Hence, to go back in for a suspected bronchopleural dehiscence is not very common in my practice. So I will actually take the patient to bronchoscopy. I want to have a look, and then if I feel that the staple line is given way or something is not right, I will re-explore. And then most of the times when I re-explore, what I do is I don't suture that area. I actually lift it up and try to put a line of staples proximal to it. So usually that area after 3 days, 2 days has become a little shabby, and I'm worried that my stitch may not stay on there. So usually I'll try and lift it up and put a staple proximal to it. Of course, sometimes you can't do it because you're worried you'll compromise the proximal bronchus. Then I will suture it. And in those situations, if I have sutured it and I'm worried about that area, I will put in a muscle flap on top of it just to get further assurance. All of this is not proven by any studies or anything like that. Most of the times you put in a muscle flap because you feel safe. There is really no evidence which says that the muscle flap is making the air leak stop. So that's the strategy for acute and non-acute problems. So the next situation is delayed bronchopleural fistula, proper bronchopleural fistula. For me, whenever I'm dealing with a bronchopleural fistula, which we all do in our careers, my philosophy is control the infection. Most important, do not rush into theater. Do not rush into theater. Control the infection. Once you've got infection under control, that is the time to operate. You must drain the infected space. So I will always put in a chest drain into the pleural space. Allow the pus to come out. Give him systemic antibiotics. Give him nutrition. Build up the patient. Then I will decide. So I don't treat immediately. I'll give him at least a week, 10 days to settle down. Let the sepsis go away. Let the nutrition go up. Then, if it's a small fistula, then I might do it via bronchoscopy. And if it's a large fistula, I will do a surgical management of the fistula. And I'll discuss about all of this in more details. So what are the endoscopic techniques available to you for bronchopleural fistulas? The endoscopic valves, which I spoke about, I think a couple of days ago when I did the endobronchial surgery, they are actually licensed for use for air leaks. So what we do is we go in with the Chartis system, and we try to find out selectively which is the area which is leaking air. And then we insert an endobronchial valve into that area and allow the lung to collapse distal to it. So this is what we do. These are the valves that we use, but this is what we do. We go in with the catheter, the balloon catheter, and we block each segment sequentially. So we look for the upper lobe, the apical, posterior. So we go segmental anatomy, and block it. We inflate the balloon and block that. And we look at the chest drain and we wait for 5 mechanical breaths. And if in that 5 mechanical breaths, the air leak has stopped with inflation of the balloon, we know that that is the area that is a problem. So moment you know that area is a problem, you deploy a stent. So what the stent will do is, not a stent, you deploy a valve, an endobronchial valve. And what the valve will do is it will block off that area and allow the airway behind it to collapse. The collapse will allow the 2 edges of your air leak to come together and that will heal. And then once you've got rid of the drain after a week or so, you make sure that the patient is stable, X-ray is fine. Then you take out the drain. And then 6 weeks down the road, you go back in and you pull the valve out. You don't leave it in there because you don't want the valve to go and get obliterated on the normal side. So you actually physically pull the valve out. So this is how the valve looks. And all you have to do is you have to catch this with a grasping forceps and tug on it and the whole valve comes out. But that is done about 6 weeks down the road, okay? So it's quite important to understand. There is a very nice paper published in JTD, which talks about bronchoscopic management of prolonged air leak. I'll just move this out of the way. Sorry, hang on. Okay, so this is in JTD. Take a screenshot of this and it talks about all the various techniques to do while you are placing the valve and how to make sure that the valve is actually closing the air leak. So it's a very nice document which will tell you. These are the papers that talk about use of bronchoscopic valves for prolonged air leaks. In Europe, it's becoming more and more common now to find that people are using valves for stopping air leaks, okay? So that's the management of acute air leak using endobronchial therapy. Now we'll talk about bronchopleural fistulas. Is everybody still with me? Are you okay?
Yeah.
Yes, sir.
Yes, sir. Yes, sir.
Yes.
Is it making sense?
Yes,
So
Yes, sir.
far we have
Pretty much.
discussed 3 different
Yes,
types
sir.
of situations. The first one was alveolar leak. That is air leak. That is not bronchopleural fistula. We spoke about alveolar air leaks. We spoke that they usually happen with the bronchus, with parenchyma of the lung. Then we spoke about what is a persistent air leak. So we tried to understand what is the philosophy of a persistent air leak. Anything more than 5 days after surgery is a persistent air leak. And then now we are in a different world. We are talking about bronchopleural fistula. These are established fistula between the segmental or the main bronchus and the pleural space, and sometimes even the chest wall. So it becomes a bronchoplurocutaneous fistula. So there are all different types of situations, and the management of this is completely different. And that is why I get very upset when somebody phones me and says, "Sir, I've got a patient of bronchopleural fistula for you. Can you sort him out?" It is not bronchopleural fistula. It is alveolar fistula. That is different. That it's alveolar air leak. That is different from a bronchopleural fistula. So it's very important to get the definition right, okay? So BPF is a communication between bronchial tree and the pleural space. And as I said, it can also become with the chest wall. And sometimes you see them happening spontaneously in patients with tuberculosis who develop pneumothorax and chronic inflammatory conditions. Post-operatively, you do see BPFs, almost all of us. There is no surgeon who can tell you that he has not had a BPF. Almost all of us have had BPFs, and the rate can vary from 1% to 15% of your cases, okay? So it really depends on the type of surgery that you're doing. I mean, if you're doing 100 lobectomies for lung cancer, for stage 1 lung cancer, there's less chance that you'll get a BPF. But if you're doing lobectomies for tuberculosis, for inflammatory diseases, then there's a high chance that you'll get a BPF, okay? So the etiologies are various. There are risk factors, preoperative, intraoperative, and postoperative risk factors. The preoperative risk factors are steroids. I do not like to operate on patients who are on high dose of steroids. I really avoid them quite dramatically. I want to make sure that the steroid is at least down to less than 10 of prednisolone per day. It's mandatory. If they can stop it, it's even better. So I don't like steroids. I don't operate on active tuberculosis. That is my other philosophy. I will operate only if I can give you at least 6 weeks of anti-tuberculous therapy. That's mandatory for me. Of course, sometimes you are pushed into it because the patient got massive hemoptysis and is life-saving. That is a different situation. But most of the times, minimum 6 weeks, but maximum as much as possible, defer the surgery, because surgery is not the treatment of tuberculosis. Medicine is the treatment of tuberculosis. Malnutrition is a risk factor because we know hypoproteinemia leads to breakdown of tissues. Active pleural infection is a real issue. Preoperative chemoradiotherapy, oh my God, you got to worry about this tissue because there's a high risk that this tissue is devascularized. You've gone in and taken the bronchus off, and then gradually over a period of time, because the vascularity is not good, it doesn't heal, and then it causes a small bronchopleural fistula, which gradually becomes a large fistula, and you're in deep trouble. Other factors are anemia, diabetes, hypoalbuminemia, all are self-explanatory. Intraoperative risk factors for a BPF are right pneumonectomy. A right pneumonectomy is been statistically shown to be more at a risk than a left pneumonectomy. If you're doing a second stage pneumonectomy, which means you did a lobectomy and then came back to do a completion pneumonectomy, you are more at a risk of having bronchopleural fistulas. If on table you have used a lot of diathermy around the bronchus and you have denuded the bronchus proximally quite a lot, then it becomes devascularized and may not heal very well. Sometimes the stapler misfires. You've used a rubbish stapler, you've reused the stapler, and it's not fired accurately across, or you've used an incorrectly sized stapler. That's the other thing. You cannot. You have to make sure that you use a green for bronchus, rather than if you use a blue on a bronchus. That's not a good idea. That will really not help. The sizing is very important. Loss of suture integrity. If you have sutured the bronchus and you have not tied it well, or it's a poor quality material, then it will break down and you will have bronchopleural fistula. And we spoke about this earlier. If you leave tumor behind, if your resection margin is not R0, there is very high likely that your bronchial stump will actually give way. Right is usually more than the left because right has got one bronchial artery supplying it, whereas the left has two bronchial arteries supplying it. So the vascularity of the left is better than the vascularity of the right. Mediastinal lymph node dissection can also devascularize the right stump. So be careful about it when you're doing these dissections. Try not to come close to the stump because you will take away the blood supply of the stump. The left, again, retracts behind the aorta after the surgery. So there is more tissue which collapses on the stump rather than being exposed to the infected pleural space. Hence, left is more protected than the right stump. The right stump lies within the pleural space. The left gets pushed away behind the aorta. So it's almost like having a muscle flap on it. So the right stays uncovered almost all the time. So that's something that you got to remember. Another thing is leaving a long bronchial stump. You must try and staple whatever you do close to the margins. If you leave a long bronchial stump, you leave a dead space there. And if you leave a dead space, then phlegm collects and blood clots collect in that long stump, and then they get infected, and then the infected air. Remember, respiratory is an open system. You're open to the air, so all the bugs are going into the lung all the time. And if you've got a little area in the lung where blood is collected, it's a beautiful culture medium, and unfortunately that infects your stump, and that will then give rise to a bronchopleural fistula. Mediastinal lymphadenopathy can sometimes erode into the area and cause problems. The bronchial diameter, which is more than 2.25 mm, can have more risk of having a bronchopleural fistula. Smaller bronchi don't give way that easily. And of course, use of blood transfusion. I think blood transfusion should be treated like an organ donation. It does cause immune responses, and there is many papers which have looked at the correlation between need for blood transfusion versus bronchopleural fistula, and there has been some association that if the patient has received post-operative blood, he's more likely to be immune compromised, or he's more likely to get a bronchopleural fistula. So it's important to handle the bronchial mucosa very gently. Don't pull and push. Don't grab it with an artery faucet. That's the worst thing you could do. So switch off your phone, yeah, guys. Who's this? Just switch off your phone. Okay. So you must avoid devascularization. Don't dissect close to the bronchus, and certainly not with the diathermy, because everything has collateral damage. You know, there is always a zone around it where the heat gets transmitted. Don't forget the harmonic is just as bad. It might be less bad than diathermy, but it still has a collateral damage. And be very careful, particularly when you're going around the membranous part of the bronchus. Sometimes those are not picked up at the time of the operation, and they give you a lot of trouble in the post-operative period. Bronchial closure should always be done without tension. Make sure whatever you're suturing or whatever you're stapling is tension-free, and avoid excessive length. So these are the intraoperative factors which will help you to make sure that your bronchus does not leak. I personally reinforce my stump. I will use intercostal muscle all the time when I'm doing infected case or when I'm doing post-operative chemoradiotherapy cases. I use intercostal because I do it by VATS or robotics. And for me, it's easier to take the intercostal muscle down. I cannot take the serratus anterior. But if you do open, then you can use whatever you're happy with. Particularly, as I said, with preoperative chemoradiotherapy, I would strongly recommend using reinforcement of staplers. If you're not suturing regularly, then you're better off using staplers. It's a catch-22. You must learn to suture well, but if you don't use, if you don't know how to tie well and things like that, then please use staplers. They're more safer. And surgical volume is important. The more surgery you do, the less is your risk of BPF, because more experienced do you become at handling the bronchus. Okay, so the expertise of the surgeon is actually a factor which helps to avoid bronchopulmonary fistulas. Post-operative risk of a BPF or positive pressure ventilation, I will fight tooth and nail to avoid my patient getting intubated post-operatively. As far as possible, I don't want the patient to be intubated. Empyema is a risk factor because of the infection. So doing a lobectomy in the presence of an empyema is a strict no-no. It's completely not recommended at all. So as far as possible, you must avoid lobectomies in empyemas, and more importantly, avoid empyemas in lobectomies. Because if you get infection in that pleural space, that's very bad news. I don't overload my patients. All thoracic surgery patients should be kept dry. The one thing I don't want is pulmonary edema and things like that, and I don't want the patient to go into failure and then end up ventilated and need have the risk of a bronchopleural fistula. Again, in my clinical practice, the chest drain comes out next morning. I have to make sure that the lung is expanded, there is no air leak, and the drain comes out. I am not worried about the amount of fluid that is coming out. There is a paper from Copenhagen which has looked at 600 ml, 700 ml of post-operative drainage, and they've looked at about 700 cases in which they took the chest drain out, even if the drainage was more than 500 ml. And only in 2 to 3 patients, they had to put back a chest drain. They aggressively take out the chest drain. The amount of fluid that comes out is no longer an indication to keep the chest drain in. Okay, very important, because the presence of the drain increases the fluid that is being created in the pleura. So we try to get rid of the drain as soon as possible. And we do not like to transfuse our patients. We are very aggressive. For us, the cutoff is 7. Only if the HB is less than 7, then we will think of blood transfusion. Otherwise, we do not transfuse blood in our patients. Acute, as I said, will be within 4 days. Chronic is the later ones, which come 2 weeks down the road when you're looking at that. They usually present with fever, coughing serosanguinous fluid. Some develop subcutaneous emphysema. Some develop tension pneumothorax. Some have prolonged air leak. Some have actually lost the drain and then come back with a new pneumothorax. So a wide variety of things. The important thing is the chest X-ray and the history is diagnostic. The moment you have a post-operative patient coming with fever, there can be only 2 causes for it. One is empyema, and the other one, the first one is of course atelectasis, chest infection, but more importantly is empyema and bronchopleural fistula, or the other way around, a bronchopleural fistula causing empyema. So be very worried about it. And the moment you see a drop in the air fluid level, particularly post-pneumonectomy, that means the fluid is going somewhere. And if you're, the only possible place where it can go is actually the bronchopleural fistula. So in a post-pneumonectomy, if you've got drop in air fluid level, or in a post-op lobectomy patient, you've got a new air fluid level in the pleura, both are suggestive that you've got a bronchopleural fistula. Very early, get a CT scan done, and please do bronchoscopy. You must not diagnose a bronchopleural fistula on a chest X-ray or CT. Every single patient must have a bronchoscopy, not just for diagnosis, but also to get a bronchoalveolar lavage and to get a good view of what is happening out there. So bronchoscopy is mandatory. You can suction out the rest of the lung as well when you do bronchoscopy. So a good toilet may actually help the patient. So this is the post-pneumonectomy, and see, these are new levels. There are multiple levels forming. Something is not right in this chest X-ray. And lo behold, here we are. If you look carefully, there is a fistula about to form in the thing, and there is a level. Can you see this level on the side? So multiloculated appearance of this fluid is not a good sign. And if you look on the opposite side, he's starting to get pulmonary infiltration. And the moment you get these pulmonary infiltration, that means this fluid is coming out and going to the opposite side. And this guy is in real danger because he will die if this lung goes off. So you've got to very quickly drain this space, put in a chest drain the space, start IV antibiotics, get him into intensive therapy. It's very important to treat this aggressively. This is an emergency, okay? Because the other lung going off is a disaster in a pneumonectomy. So it's very, very, very important to start working. Sometimes you get these fistulas coming out from the skin, a bronchopleural fistula. Look at this here, you've got a collapse consolidation. Something is not right, the lung is not expanded, and there is a loculated cavity. All of this are suggestive that things are not going right, and he's not doing very well. And in fact, you can see a chest drain on the other side as well, which means he's probably had a large pleural collection, and things are not going well for this patient. This is the sort of sinuses that you get, a chronic tuberculous fistula, which is probably originating from the leakage of the bronchus or the lung, if it is left behind, and then the TB thing erodes into the bone, causes osteogenic tuberculosis, and then they leak out as a cold abscess. So quite a difficult situation when you have these pleurocutaneous fistulas following this. So you must, when you're dealing with chronic fistulas like this, you must do a sinogram, because you really want to know where the tract is going. And many a times it will not just be one tract, but there'll be multiple tracts going in. And in this particular patient, there was one sinus on the side here as well, and he had a previous thoracoplasty. As you can see, this is all collapsed because of the previous. So recurrence from the sinus is always a problem. So when they come with these things, they are real issues, social issues, sexual issues with their family life, psychological issues. And then, of course, the chronic sepsis, nutritional depletion, multiple surgeries in the past, and many local debridements. All of these are technically a real challenge, and you have to treat these people aggressively. The answer is you must be aggressive in your management. So first and foremost, whenever you've got a bronchopleural fistula, make sure you drain the affected side. Drain it. You must get the pus out. You must control the sepsis. Do not attempt to close the fistula until and unless the sepsis is under control. And then you think of doing something for the pleural cavity or that fistula, okay? So the thing that you do is you go in there later on with surgery, and you might have to debride the bronchial stump. You might have to close the bronchial stump, and you might have to fill in the space with good muscle flap or omental flap. And I'll show you that in a minute. So this is a chronic infected space in the chest wall, probably because of some fistula here. But there is now the suction therapy available. This is a vacuum suction therapy. You put in the sponge, and then you connect it to this vacuum suction, and then you leave it to heal over a period of time. You have to repeatedly take the vacuum out, and with time, you will find that the cavity gradually starts to reduce in size. Antibiotics start to take hold, and very often you might get away without doing any radical surgery for these patients. So this is a new technology in the market which can be used for a chronic infected space of the chest. You might want to do something called as a Claget's window, which means you do a window on the side and allow the pus to drain out. You might also want to do something called as an Elozer flap, and I'll tell you the difference between the two. And then once you've got control of the infection, you might later on want to use muscular or omental flap. And the last option available to you is a thoracoplasty, where you might drop the whole chest wall to reduce that large cavity. Bronchoscopic management is anecdotal. There has really been no randomized controlled study for management of a bronchopleural fistula, but works for small fistulae, but the recurrence rate is quite high. And I'll tell you about the ones that I have done. We've used a variety of things. You can use a blocker, you can use a synthetic agent in that area, or you can use a valve. All three of them have been tried for management of bronchopleural fistula. I have personally used Sealant a few times now. A colleague of mine has used cyanoacrylate glue. My worry with cyanoacrylate glue is it sometimes damages the bronchoscope as you try to bring it out. So it's quite expensive when the bronchoscope gets damaged. Tissile at least you can wash out. So, but you've got to be very careful that when you inject the tissile through the bronchoscope, you must never pull that catheter back into the channel of the bronchoscope. You got to leave it outside beyond and pull the whole apparatus out so that no agent gets into the bronchoscope. So this I showed you in that endobronchial surgery. These are the sort of infected pneumonectomy spaces that you got. So when you go in there, you actually use a brush and erode the mucosa so that your sealant, whatever you're going to put afterwards, actually attaches itself to the mucosa. I managed to find a video on one of my patients. So this was, I think, a post-pneumonectomy fistula, and a small fistula at that stage. And we went in, we sucked it all out. And this is my brush going in there. And I'm actually brushing the mucosa to show you how we do this procedure. So you just create an abrasion on that area so that the glue has some legs to stand on. And then once you've done enough abrasion, then you get in there with your glue and you inject it. So here we are bringing in with the probe, and we are gradually putting in droplets of tissile. You can do whatever you want. There are various things available for plugging this area off. If it's a small fistula, it works. But if it's a large fistula, it will invariably get coughed out. And that's the worry. So you got to be careful about it. So this is the sort of outcomes that you will get when you put in the tissue, okay? The other literature available for endoscopic devices there's a nice paper from Pune. This group has done about 12 cases, and they have actually come up with a nice flow chart. And this is a pulmonology group, I think. And they've used endobronchial coils with sealants in bronchoscopic fistulas less than 4 millimeters. They have used ductal occluder devices in 4 to 8 millimeters. And they have used an ASD implants device plus a covered stent, tracheobronchial self-expanding covered stent for fistulas more than 8 millimeters. And I was surprised to read this paper because they have got patients who are actually now at 24 months following the procedure. These are post-tuberculosis chronic fistulas, and they are 24 months post-procedure, some of them, and they still have closure of the fistula and no recurrence. So, but it's not been published in a proper, big journal. It is one of the smaller journals that this paper has been published. So sometimes, when you have good results like these, you must have the courage to publish it in international journals so that we can, use this as a standard for future devices. Let's look at other surgeries that are available to you. So a Claget window. Claget window is like a rib resection and drainage. You create a window to allow the pus to come out. This is from the ESTS textbook. So you make your incision, you dissect out the area, you make a cut on the rib and take out 1 or maybe 2 ribs. Here he has cut 3 ribs. So it's usually a much larger cavity, Claget window. And it allows the pus to drain out and gives you an acute control. And at the end, you just put a stitch to epithelize the edge of the thing. And then these Clagett windows are usually used as a temporary measure. You're hoping that over a period of time, you would be able to close these. This is just to temporize the patient, get rid of the sepsis, get the patient fit enough, and then continue medical therapy. So the NITDR guys do a lot of these window procedures, and they swear by it, and they've got very good results. I have listened to Dr. Diwan talk about his experience, and they've got very good results with Clagett windows. So the difference between Clagett windows and Elosir flap is Clagett window is a larger area. You really want to get all of the pus out, and it's a temporary measure for decontamination. And the aim is always that subsequently you will actually close the Clagett's window. That is what you're hoping to achieve when you do a Clagett's window. As opposed to that, when you do an Elosir flap, it's a more permanent drainage of pleural space. It's a smaller hole than a Clagett's window. And this is the description of an Elosir flap from the original paper. So Elosir flap is done with an inverted U-shaped incision at the bottommost area where you want to drain. You want to make sure that the drainage is as low as possible. And then you create this mucocutaneous flap along with the latissimus dorsi. And then you take out the ribs and come as low as the diaphragm, and then push in that U-shaped window into the cavity so that you create a flap. The flap goes in, and so you do not get closure or epithelialization of this flap. So this way, this stays open longer. In fact, the design of it originally was that it should stay open for life. But there are a lot of social issues with these, and I'll take you through some cases. This is really a disaster story of a young girl, and I'll tell you about it in a minute. So this is the sort of Clagett window, but it is not great for the patient's social life, because look at the amount of erythema that is happening around here. Look at all these encrustations, and look at the number of thoracotomies she's had, multiple surgeries. And this young lady, unfortunately, was a doctor actually. And she went in for a resection of a small tumor in her first MBBS. And that got infected. And subsequently, they had to do a lobectomy, subsequently a pneumonectomy, eventually ended up with a Elosir flap. And the whole thing continued to drain pus all the way till her final MBBS. And I saw her in her internship when she said, I want to do MD medicine and I want to get married, but I cannot get married with this window. And I'll tell you her case in a minute. So let's go through this. Whenever I am dealing with a case like this, I will always do it with my plastic surgeons. I feel that these patients have only one chance. I know I can take a muscle flap. It's no big deal. But the plastic surgeons are doing it every day. They understand the vascularity of these structures. They treat the tissue different from the way I treat tissues. So I will always do a combined surgical intervention with the plastic surgeons. My aim is to get rid of all of that sinus, completely debride that pleural space, and refashion that bronchus. I want to close the bronchus on table. And then if needed, I might complete the lung resection, whatever is left behind. And most important is to close the stump properly and put a muscle flap onto it. And then my plastic surgeon colleagues will get in. So for flaps for stump sinuses, I use an intercostal muscle pedicle. If serratus anterior is available, good enough. Pericardium or fat, whatever is available in that area. If it's a post-pneumonectomy space, I do use the phrenic muscle pedicle. I cut off the phrenic and I swing it around along with the vascularity and a little bit of fat and use it as a pedicle on the stump to cover it. That has dual advantage. One, the diaphragm comes up, so the cavity goes down, and so it's easier to fill in the space. And then sometimes you can use diaphragm as a rotational flap. So you can actually incise the diaphragm, part of the diaphragm, not full thickness, half thickness, and swing it around onto that pedicle. And sometimes you might even use thymus if it is available in that area and if you can get into that. The problem of trying to do something with the stump is that there is always fibrosis in that area. And if it's a post-pneumonectomy, it's almost impossible to know where is the pulmonary artery stump next to the sinus. So trying to refashion the stump or trying to refresh the edges or trying to put sutures through the stump never works, because the risk is that your suture may go through the pulmonary artery. And if that happens, you will lose the patient, because there is no way you can get into the pericardium, because this is all stuck. It's all a badly infected cavity. So I try not to refashion the stump. I actually take a pedicle muscle and I will put it back on there and plug the stump. That is my preferred strategy. I use a muscle pedicle and plug the stump. And then I do rib resection to maximum, whatever is needed, but never ever use mesh or synthetic material. Never ever. These are infected spaces. You must not use any synthetic material. The reason why I do these with plastic surgeons is that my plastic surgeon assures me that you debride to maximum, I can fill any hole in the chest. I am confident of filling any hole. So when you are with somebody like that, you become more aggressive in your approach to taking care of infection. And then my plastic surgeon comes in, he will take out anything. He'll take out muscle, pedicle. When we go in, we try to harvest whatever is left behind, latissimus, pectoralis. He will do the reconstruction, and then we always close primarily. We've done this in at least 20 patients now, and we close them primarily. And we've had good results in all of them. So far, we've never needed to use a free flap, but that option is also available to you if you need it. The muscle flaps that we use are latissimus dorsi, but the problem is they have been damaged by previous thoracotomies. We use pectoralis major muscles. We use serratus anterior, if available. Sometimes we use rectus abdominis. So we can flip any of these muscles across into the cavity. So this is a large incision that you do. Then you harvest the muscle, whatever is available on the surface, and then you roll it into there. That's the strategy. So I'll show you some cases which we've done. But the important thing is this muscle flap must come on the fistula, but try not to take stitches on the bronchus. This is intraoperative, but I don't take any stitches on the bronchus. I'll just fix it to the surrounding tissue so that it just plugs into that area. Okay. So this, let me show you a case like this. This is the sinus. He's had multiple surgeries in the past. He's also had a partial thoracoplasty, but the sinus has come back. Not great situation for him, but I know that the sinus is just the tip of the iceberg. It is going deep inside. I've done a sinogram. I know exactly what is the situation. There's osteomyelitis in the 7th rib, osteomyelitis in the 1st rib. So you inject all these sinuses with methylene blue. You harvest any residual latissimus dorsi, but the most important thing is all tracks have to be followed to the bone, and there must be an aggressive surgical resection. So you've got to take everything out, and then you take all the muscle, see all these sinuses coming from various areas, you take all of this out, and then you put everything back in, and these patients then do well. I have followed this guy up about 6 years down the road, and touch wood, so far he's not got any recurrence. And you know, everything is healed. There is a technique called as a transsternal repair of the bronchial stump in a pneumonectomy, because when you come from the side, you really cannot see where the stump is. So there is a design where you come in from the midline, sternotomy, you go in, you put snoops around the aorta and put snoops around the SVC, and you open it up. When you open that, you actually see the bronchial stump, and you re-staple it proximally, much proximally, so that you get a healthy tissue. See here, they've re-stapled it much proximally. And Dr. Ball has done a few of these cases, and I listened to his presentation, and they have got really good results with this technique. So instead of doing everything on the side in the infected area, he goes into the midline, and he does that, and he refashions the whole stump and puts a staple line proximally, and that helps you to get a good control of the bronchopleural fistula. We use omentoplasty extensively in all our cases. We will harvest the omentum, and the omentum can reach a very long area. So we sling it in a subcutaneous tunnel and bring it into the, from the lateral side into the chest, and then we push the omentum completely to block it. So here is a 17-year-old guy with Ewing sarcoma, had some chest wall surgery, had some mesh repair, got infected, complete mess inside, Claggett window, and for many many months he was struggling with all his problems, secondary to decortication, lobectomy, and really in a bad way. And we went into the chest and we opened up everything, really debrided it completely, completed the rest of the lung resection. And then my plastic surgeon got me the omentum, beautiful piece of omentum. He slung it in a subcutaneous tunnel across from the abdomen, and then we placed it in there, and we used whatever local muscle we had to cover it. And this patient went home without any problems, and he's now, I think, 7 or 8 years down the road, and he's never had any recurrence with this. This is the young lady I was telling you who had pneumonectomy, had bronchopleural fistula, Elizor flap, draining for 5 years, real disaster. And she came to me and said, I want this out. And then we went in, again, same concept. I did a bronchoscopy. See, it's very difficult to find the fistula when you go from the side because it's all infected and pus is there and there's adhesion. So what we do is we do a bronchoscopy, and under vision of the bronchoscopy, we pass a guide wire across the stump fistula. And once you pass the guide wire across the stump fistula, you then intubate and get on with the surgery, leave the guide wire in place. And then when you go from the side by thoracotomy, then it's very easy to find that guide wire. And once you find the guide wire, you know exactly where that fistula is. And all you have to do is plug the fistula. So you debride the rest of the tissue. And this is, you're pushing it from the guide wire from the bronchoscopy. And then you can see the guide wire on the other side. And then when you get into theater, you harvest whatever you have to. We took the intercostal muscle flap. We had residual latissimus dorsi. We did a laparotomy, got the omentum out as well. Again, everything was closed. Everything was cleaned up. Again, as I said, you cannot suture the fistula because you don't know where the artery is. This is the important bit that you have to remember. It's a messy area, and the last thing you want is bleeding. So all we did was push the muscle onto the stump and then push the omentum across through a subcutaneous tunnel, came into the chest. And then here is the omentum coming from here. The muscle is coming from this side. You can see the muscle coming from this side. And so this is the muscle covering the fistula. This is the omentum covering the entire chest cavity. And then you close it primarily. The key thing is to close it primarily. And we are so happy to know that this girl has now actually done her master's in MD medicine. And, eventually, hopefully she will get married sometime in life. So look at the outcomes. 5 or 6 or 7 years she was struggling with this, and here she is completely gone and doing very well. So the last thing to talk about is thoracoplasty. Thoracoplasty, Dr. Rajan Santoshan gives one of the best lectures on thoracoplasty. He's got a video which he has published, a beautiful video, and this is actually from the ESDS textbook, which the chapter on thoracoplasty is actually written by Rajan Santoshan. So this is directly from that. You make a large thoracotomy, go into the subperiosteal area and dissect out all the ribs depending on what is the level that you want to do. You can do 2 to 7 ribs depending on whatever level you need to get to. Cut the ribs posteriorly, cut the ribs anteriorly, and take out all of the ribs in one place, and then dissect in the extrapleural space and allow the whole chest wall to collapse into the chest. This way, the whole chest wall collapses into the chest and actually obliterates the space and the cavity. And he's got excellent results with these technique over the years. But of course, now with the modern medical therapies, the incidence of tuberculosis is treated more and more medically. And with the intervention of these other techniques like muscles and omentums and things like that, in a lot of places, the incidence of thoracoplasty has gone down. But in India, they still continue to do thoracoplasty and they still have very good results. Rajan Santoshan and Dr. Diwan, both of them have excellent results with thoracoplasty. And even Sri Krishna in Bangalore has very good results with thoracoplasty, and they publish them and I've seen them. And I'm quite impressed with the way they do these surgeries. In my personal practice, I don't see these sort of patients, and I really go more down the route of the plastic surgeons and me getting together to close it. So really, these are very, very difficult problems to treat. These are patients who are in deep trouble, but you've got to be aggressive. You've got to be multimodal therapy. multi-surgeons, plastics and thoracics together. The bottom line is, if the surgeon is worried about reconstruction, he will not do adequate resection. So that is why I always do it with my plastic surgeon colleague. It's harrowing surgery. I think it has had its toll, really. TB surgery, I have paid a big price, but my wife is happy, so it's okay. Thank you very much, guys. Okay, I'm going to stop share. Now, I have a whole chapter. Okay, are we back in? Hello? Can you hear me? 1 minute.
Sir, your microphone is off, I think.
Okay, did you guys hear my talk or you didn't hear my talk?
No, we did
We
not.
heard your talk.
Hello?
Yes,
Was
sir.
it off all the
We
time?
heard the talk, sir.
Yes,
Audible, sir. Audible.
Audible? No, I didn't talk for 2 hours and nobody listened.
No, not
No,
that.
sir, no, sir.
It is the last just 2 seconds.
Okay. Thank you. Thank God for that. I was suddenly worried that I spoke for 2 hours and nobody heard. Okay, all right. Tell me. So, did this make sense?
yes.
Questions. I'll take questions now. Now, I have a whole chapter on. I have a whole chapter on intercostal drain insertion, which I will not do today, of course. But I really think that you guys must know all the possible questions on chest intercostal drains. It's very important. And if you don't answer these questions in the exam, you look so foolish. So I will do that one of these days. I prepared a whole talk, and I was surprised how much you can actually be quizzed on. We'll talk about it another day. Today, I'm happy to take questions. I'm so happy to see Dr. Babatosh on the crowd. Namaskar, sir.
Namaskar, Jamil Sahab.
How are you, sir?
I have been enjoying your lecture.
Oh my God! Don't tell me. I didn't realize you were there, sir. Questions. We'll take questions, guys.
Namaskar to Bhavatosh sir.
Namaskar to Babatosh.
Namaskar, namaskar.
So we'll take questions, guys. Anybody